for today's webinar on Housing First. Before we get started, I want to provide you with logistical information. Make sure you can get online while we talk so you can access the visual component of this presentation. You should have received an email from me yesterday and again this morning. First, click the ReadyTalk link, enter your name, email address, and click Register, and you will be given access to the meeting. If you have any questions throughout the presentation, please type them in using the chat feature in the lower left-hand screen, and we will open up the line for discussion and questions at the end of the webinar, and we will make sure all your questions are addressed. Finally, the PowerPoint presentation will be sent out after the webinar today. It's my pleasure to introduce the person I think of as the expert on Housing First. Chris Cimariglia established Pathways to Housing PA in Philadelphia in September of 2008. For 15 years prior, Chris worked with the Mental Health Association of Southeastern Pennsylvania, leaving the position of Vice President in 2008. She has worked in homeless and behavioral health services since the late 80s. In between, Chris has done consulting work in various service systems focused around management for nonprofits. She has had several papers and toolkits published that relate to her work with people who are homeless and have disabilities, and hopes to do more knowledge dissemination in the coming years, helping other communities to establish Housing First programs. On a personal note, she is married to the love of her life, another presenter of a webinar for the Housing Alliance, and lives with her 2 rescued dogs. She knits, gardens, and quilts in the rare moments when she's not working. It's really my pleasure today to introduce Chris Cimariglia. Chris?
Thank you, Joyce. Before we get started, I want to say something that people sometimes don't expect. Yes, Joyce?
I'm having a little trouble hearing you.
All right, let me see if I can correct that.
Okay.
Is that clearer?
Yes, much.
Okay. Sorry about that.
That's okay.
So I'm making a note that speakerphone does not work for this. Hold the phone. Okay. One thing that I want to start with is to say that, Housing First is a term that we're hearing a lot, and it's being required now, connected to a lot of funding streams. But Housing First is not the be-all or the end-all for our communities, for homeless services. Housing First works very well and gets really good outcomes with certain sectors of our population that need the service, but it is a piece in a pie, and every continuum has to have a lot of different pieces to their pie because choice is what works for people. So I'm going to talk about Housing First. People are getting really frustrated hearing all of the Housing First rhetoric because, when there is something new that the federal government is purporting, they tend to push it as the be-all and the end-all. So I want to humbly submit that it is not, but I'd like to tell you what it is. So I'm going to run through some slides, and I talk fast. I am a Philly girl, and we talk fast. But I'm going to ask you to keep a running list of your questions, and we're going to try and get to as many of them at the end of this as we can, because I'd much rather answer your questions than talk for the complete hour, because you'll learn more by asking what you want to know as opposed to me telling you what I think you should know. And also, I want to let everyone know that I am more than happy outside of the webinar to answer questions, and people can email me, and my email address will be provided toward the end. So with all of that, let's talk about Housing First. So a lot of people, a lot of communities that I visit around the state say, and around the country, aren't we already doing Housing First? Well, we have this program, we have that program, we're doing Housing First already. So I want to make a distinction. As a philosophy, Housing First, with a lowercase h and a lowercase f, is about moving homeless people into a multitude of housing options as quickly as possible. Sometimes that happens without adequate services and supports. That's not the type of Housing First that I'm going to talk about. Housing First as a model, the best practice model that's been recognized by the Substance Abuse and Mental Health Services Administration and by HUD, is a model that uses an assertive community treatment or intensive case management service model to work with people with the most complex needs in accessing and maintaining community-based scattered site housing. So that's, we at Pathways, we do the number 2 model. The number 1 model is being used a lot, but the outcomes are different than what the literature around the best practices discusses. So if you do the model with fidelity, you'll get the outcomes that you see in the literature on the best practice end. If you do something in between, you may actually get some good outcomes, but they're not going to be the same, and people's expectations just need to meet what the level of what they're doing. So when we look at doing housing first, there's a lot of energy that needs to go into targeted outreach and engagement, meeting people where they are, literally. The fact of recognizing that kindness is magical. You treat people with respect and kindness. You see to their wants and their needs. A cup of coffee, a smile, sitting on the pavement, it goes a long way. And a lot of times, we go out and we do outreach and we think we know what people need. And a lot of times, sometimes, we do know what people need. People don't necessarily respond to their needs. They respond to their wants. So we try and start with people's simple wants and deliver on those, and that allows us to then move into talking about their needs. Being goal-centered, having a goal in mind before each engagement based on the last engagement, not just going out constantly saying, do you want an apartment, here's a cup of coffee, but really starting a goal-based case management relationship with someone maybe before they're enrolled in your service, when they're just starting out in the outreach and engagement level. Never promise what you can't deliver, but do make promises. Following through on really small promises helps to build trust. And, for this model to work with the people that it works with, people who have been out on the streets for long periods of time, have multiple disabilities, have serious and persistent mental illness, have drug and alcohol addictions, have intellectual disabilities, have physical disabilities, have a bunch of chronic medical issues, one piled on top of another, piled on top of another. Delivering on small promises is a big deal, and trust is a big deal, and those little things help to build trust. Offer options. Choice is what works with people. People need choice. Understand that no means no for this visit. If somebody doesn't want to visit with you or they don't want what you're bringing them, that's okay, because we'll keep coming back. And that's part of building relationships. It's keep coming back, building the engagement, building the friendship. Now, all of that sounds great, and a lot of people have outreach programs and they're doing things like that. But the one thing that's usually missing when we talk about outreach and engagement is the money to pay for it. So a lot of times outreach and engagement is not paid for with the same dollars that case management is paid for. And communities need to look at creative ways to make sure that that important part of relationship building is in place. COCs and community providers, when we talk about targeting and supporting outreach, need to develop lists of targeted individuals for their Housing First services. And then outreach workers have to have the stuff available to them as needed. They need to have access to petty cash. It needs to be okay to buy somebody coffee and get reimbursed for it. And for some agencies, it's not. So, it's a culture of small things like that being okay. It needs to be okay to get somebody a sandwich. There need to be blankets and coats and transportation available as necessary. And when someone is really ready and willing to come in, the worker needs to be able to access housing services, furniture, and housewares almost immediately. So that's kind of all of the pre-work that an agency needs to do. It needs to have those things in place so that when they're working with a really difficult client or a difficult population, when someone is ready, we have the things that are necessary to move them in. I think some of my slides were out of order. I apologize. So when we're talking about coordinating and paying for outreach, coordinated outreach and knowing your population and sharing data is really important. So in Philadelphia, we've been really lucky. We've had a coordinated outreach effort for 25 years, and we've been collecting data for that long. So we kind of know who's on our streets. We participated in the 100,000 Homes campaign several years ago. We got to rank that data. On a regular basis, all of the outreach agencies in the city get together every month and sit down around a table and look at the data and make decisions about who's best served by which agency, based on need, based on what that person has said they want, based on area of the city where they want to live. And that needs to be something that every community does. There needs to be a way for everybody to sit around the table and know each of their chronically homeless people by name and to make decisions about how to serve that person in a group based on data. And if you haven't started collecting data, that's something we need to start looking at. And then I've already mentioned that no one wants to pay for outreach. So finding money to pay for outreach is really important. We, with our outreach teams, with our assertive community treatment teams, we build outreach into part of our rate. Because we know that we're going to have turnover and we're going to have to continue to do outreach to bring in new clients. And that is part of each case manager's job, and building it into the rate makes it much more doable. So it's something to think about. We want to use data-driven priorities when we're looking at where to target Housing First resources. Housing First resources tend to be few and far between because it is a marriage of a housing subsidy and of a level of services that tend to be precious resources in our communities. So we really want to make sure that the people who need that service the most is getting it. So when I talk about this meeting that happens every month, part of what we do is, we look at the outreach data to see who the outreach workers around the city are seeing on the streets. We look at who's using our emergency departments. We look at who's being seen in our shelter system, the public shelter system, who's using the behavioral health care system, who's going in and out of jail, who's most likely to die on our streets. We overlay different data sets, and then we rank people based on acuity level. And the people who have been out there the longest and are the sickest, for the most part, are the people that get moved up on the Housing First list. We serve the hardest to serve individuals. So, we're not the be-all and the end-all, but we are a piece of the continuum that's been missing in many of our communities for a long time. And this model typically works best with your sickest, longest-term homeless folks. Your most difficult to serve citizens, the folks that have either not worked out in every other program that your system has to offer, or who have never really connected and have stayed under the radar. You don't want to be afraid to take on this population. If you do a high-fidelity model with Housing First, you'll be successful in ways that you never imagined. So what do we do? So in Philadelphia, we're really lucky in terms of, and I know this is different for a lot of other places in the state, so I know that we're lucky, but it doesn't mean that it can't be done in other places. We have a sufficient amount of rental housing in lower income neighborhoods that falls under our FMR with HUD. I know that that's not the case for some communities. It is the case for other communities. It doesn't make it impossible, it just makes it a little tighter when you're looking for housing units. But even in the fact that, we are a very poor city, I think most people know that Philadelphia has a 26% poverty rate, and over half of that is deep poverty. There's a lot of competition for those really cheap priced apartments. So how do we find apartments? Landlords generally like two things. They like money, and they like not to be bothered a lot. So, the subsidies and vouchers take care of number one for us. So we have worked really hard and have a number of different HUD grants that pay for a lot of the subsidies on our apartments. We've also worked very closely with our housing authority. So we also have vouchers through the housing authority that we work with. Now, truthfully, we like the subsidies from HUD better because the subsidies from HUD are, for the most part, in our name. So when we lease a unit, the tenant is Pathways to Housing. And then we create a sublease agreement, a use and occupancy agreement, that's what we call it, with our clients who are going to be the tenants of that apartment. This allows us, as needed, to move people around, maybe without going through an eviction process, because when people first come in, they may go through 2 or 3 units. They are people that have not lived anywhere for a long time. There are, it's a foreign land for some people to move into an apartment after being on the streets for a long period of time. So it takes some getting used to, and sometimes there are behaviors that would normally get someone evicted. We have the flexibility to move people from one unit to another without having to go through the whole legal process. And sometimes the second or third unit, something clicks and they're much better. So we prefer having the subsidies and being able to do that. When we use vouchers, the lease is in the client's name. It makes it a little more difficult for us to intervene. But it still works, and there are ways around working with the landlords in a voucher situation, and we're always happy to talk to people on how to do that. So housing first agencies really need to concentrate their energies on number 2, which is the don't like bother. So one of the things that we've done is we've created a housing department. So we have a number of maintenance workers that work for us, and we have a really great director of housing who has incredible relationships. So we treat our landlords not necessarily as vendors, but as partners. We do quarterly networking events for the landlords where we do networking and training with them, where they can really feel a part of our agency, and they can feel in a different way than a vendor would that they are helping with a societal problem. And truthfully, we rent low-rent apartments. There are a lot of people that live in the buildings that our landlords own that have, similar issues that some of our clients have, and when there is a problem, the landlord has no one to call for that person. Whereas if something happens with one of our clients, they call us. So now we have a relationship. If somebody happens with someone else in the apartment building that's not our client, sometimes they call us and we try and help, and that's part of a partnership. But we also try and train them on what they can do that helps that person and also helps them, because if they help that person might be able to stay in the unit. So we've trained people on how to use the emergency psych system in Philly, how to call the mobile emergency team. We've trained them on the nuts and bolts of being certified with PHA. We've trained them on mental health first aid. So we've offered trainings so that they feel like they're more a part of the agency. So that's something that we recommend. They're not just vendors. You have to have, well, you don't have to. It works best when the people managing the housing work for the same agency as the people doing the services. It gives you a lot more flexibility in your ability to support the client as well as to support the landlord. The services that we provide, as I mentioned earlier, are ACT and intensive case management levels. So the first teams that we had 2 teams that were at ACT level of care. So we provide a non-fidelity assertive community treatment service. And we say non-fidelity because in Pennsylvania, we don't bill under ACT. For people that are familiar with the case management system, we bill under blended enhanced case management. And we do that because it has a lot more flexibility in terms of billing and services, and we feel that it is a lot more recovery-oriented. We now have several teams that are non-Fidelity Act, and we just launched a team for people that are graduating out of the ACT level of care and are doing really well and don't need that level of care. And we've graduated about 70 people into a lower level of care. And these are people that nobody thought would come in, let alone would ever be able to be managed in a lower level of care. So it's kind of exciting. We have multidisciplinary teams. The teams include, at a minimum, a team leader who's master's level. We look for LCSWs. That's our kind of wants. But we do have some team leaders that are MSWs that are working toward their LSWs and their C. We have a part-time psychiatrist. We have half-time psychiatrists attached to each team. There's a nurse, and we recommend for this kind of work that the nurse be bachelor's level and not just associates, because it is a lot of independent work without a lot of nursing supervision. We have case managers. We call them service coordinators. They are bachelor's level for the most part, and they have different interests. So we have case managers that are drug and alcohol specialists. We have somebody that's a forensic specialist. We have someone else who's a geriatric specialist. So, depending on who's on the team, we have different people who are specialists in that area and are liaisons with those other service systems. We have a certified peer specialist on each team, and then there's an administrative person who kind of manages the team, the paperwork of the team. We also added an assistant team leader, which is not a requirement, but it's a master's level person, because being a team leader it's an interesting position, and it really is an experience that requires a lot of learning in this environment. And so we decided to add an assistant team leader position so that there's always someone being groomed to move into the team leader position when something opens up. We have access to a primary care physician, which started out with us accessing a primary care physician through Jefferson Hospital that we were paying for, and has recently morphed into our being a satellite site of a federally qualified health center in Philadelphia. So we have 2 exam rooms, and we function fully as a satellite site of a clinic, which has been wonderful for our clients. We have a housing placement specialist. We have community integration specialists and a benefit specialist. The community integration specialist staff, their entire job is helping people to be of the community and not just in the community. So it's interesting. So most of our services are provided, and helping people with their ADLs, their activities of daily living, and community integration skills are at the top of our list. What I found is for a lot of housing programs, getting somebody housed is the end game. For us, it's kind of the opposite. Getting somebody housed is the beginning. Getting them, helping them to be part of the community, to feel like a neighbor, to be normalized in a neighborhood, that's the end game. And so that requires, for people that have been, for the most part, ostracized from that type of environment for a long period of time, a lot of work and a lot of skills building. And sometimes it's more than the case managers can do. I mean, their day is around getting people to medical appointments, putting out fires, making sure somebody paid their rent, like this million other tasks that, keep somebody, well and stable in their housing. But the extra stuff sometimes falls by the wayside. And so we have staff who their job is to do the extra stuff. Their job is to help people learn how to sit in a restaurant and have a conversation and order again, which we take for granted as a normal part of living, but some people don't. To teach people how to shop and how to buy green vegetables and cook them, because people have been eating packaged food at soup kitchens for many, many years. To help people find a church or a home group that they're comfortable with. So all of those things get folded into our community integration work. It's a lot more than case management. So within the agency, we, it initially set up to manage people's housing placements and their retention. We provide people's mental health services. We provide some DNA services in-house and referrals out. We provide primary care services. The goal is to eventually have everyone plugged into the community and not need us to provide those services. But the reality is, for people that have been, outside of our systems for so long, there's a bridge that's required. And that bridge can be required for years. It just depends on the person. We also have found that we need to provide representative payee services for many of the people we work with. And we're currently rep payee for about 250 people. All the apartments that people move into as past police clients are furnished, and housewares are provided. So when people sign their lease, they go shopping, and they get everything they need to start, from shower curtains to sheets to dishes to pots and pans. We manage a small food pantry because we have people without income, or, as we know, Social Security income doesn't always stretch till the end of the month. And there are times when people need help with stretching it. So we have developed a small food pantry, and we help people do that who are part of our program. And basically, with all of those things, our staff has a whatever it takes attitude around housing retention. People around here don't say, that's not my job. If they go into a house and it's filthy and, and the person needs help cleaning, they don't stand around explaining how to clean. They roll up their sleeves and they get out the cleanser and they, scrub the toilet, because that's what needs to get done. So I'm going to talk a little bit about harm reduction. Harm reduction makes people's skin crawl sometimes, and they get goosebumps and they get all nervous when they talk about it, because we spent a long time as a state and in Philadelphia as a city community, and put a lot of money and effort into a lot of clean and sober recovery services. And they're all great, and they work really well with a lot of people, and people have gotten their lives together and reunited with family and gotten jobs and dealt with their addictions in that system. But there are people who haven't. And again, when we talk about needing different pieces of the pie, harm reduction is another piece. So what is harm reduction? People marginalized by high-risk behaviors have the right to access a continuum of service options and strategies that include outcomes such as reduced harm experience, abstinence, and enhanced quality of life. The philosophy of harm reduction recognizes the resilience of people who engage in these behaviors and aims to reduce stigma associated with them. Harm reduction does not promote or enable harmful behaviors, or, and this is the important part, protect individual participants from experiencing the consequences of the choices they make. Harm reduction doesn't mean anything goes, and there always need to be consequences for people's actions. So harm reduction is not for or against drug use. Harm reduction looks at a drug user and says, this person is using. How do we reduce harm? It's not consent to use drugs. It's not a don't ask and don't tell rule. It's not an anything goes rule. It's not anti-abstinence. It is not anti-clean and sober. It is not enabling. It is not use without consequences. Again, it's about choice. We know in most situations in life that we do better when we have a choice. People moving off the streets need to be able to choose a neighborhood, choose an apartment within that neighborhood, and, when able, choose the furnishing for that apartment to the greatest degree possible. Forcing a choice of a unit on someone has the same effect as forced treatment. People leave. We really try and have several apartment units available for people to look at when they're ready to come in. We ask people where they want to live. Some people want to live in the neighborhood they grew up in. Some people want to live as far away from that neighborhood as is humanly possible, all for different reasons. And we recognize that home is a lot more than four walls. It takes a concentrated effort by the entire team to help a newly housed person create a home, and a home that they want to stay in. I want to talk a little bit about organizational culture. It's really hard to squeeze a Housing First program with a capital H, capital F, that's based on a harm reduction model into an agency that's built on a traditional housing hierarchy. And by that I mean you have to go to shelter, and if you do well there, you can graduate to transitional housing. And if you are, clean in the housing and you come in on time and you don't bother your neighbors, you might move into the next level. All of that is good. It works for a lot of people. But it's a different way of doing business. And it's built a lot of times on clean and sober services. Neither is better or worse. They're just different. And they work differently with people. And trying to manage two very different cultures under one umbrella or one roof can be really painful. And it can cause a lot of problems in both cultures that lead to turnover in your organization. The beliefs and probably a hefty part of the budget of a traditional services agency is at odds with the model, because a lot of our agencies own buildings. You might work with an agency. You might be in an agency. You own buildings. You own buildings where you have shelter. You own buildings where you have transitional housing. You own CRRs. You have buildings where there's, 12 people living together and it's staffed. That stuff's all great. And then, Housing First comes in, and some of our funders are saying, well, why don't you convert some of your housing to a scattered site model and do Housing First? And then you're stuck with this building. So now you're like, well, what do I do with this building? I have to pay for this building. We own this building. And it requires a lot of creative thought about what to do. And a lot of agencies don't want to wrestle with that real estate issue and some of the other issues that come up, which have less to do with the model and the clients and more to do with money. And that it's hard to reconcile them. The organizational culture in a Housing First agency is one of community. So community really values taking care of each other, our teammates, our clients, and ourselves. And we do a lot of work. This work is really hard. When you get into a zone where you're kind of doing whatever it takes to support the people you serve, it takes a lot out of you. And so, the agency and your coworkers need to be doing whatever it takes to also help support you, and you help support each other. We put a lot of emphasis on and a lot of energy into self-care. Because people are doing really hard jobs, and it's nonprofit wages. So, we do what we can to honor them. One way we do that is to offer a really decent benefits package, because we can't, pay people the wages that we'd like. We offer training money. We, have a good bit of vacation time. When we have a meeting, we feed people, and we try to make every meeting a welcoming environment that people want to come to. We offer good technology that helps them with their jobs and to get through their day. And a lot of our staff are younger social workers, and the technology thing is a really big deal to them. And if the agency provides them with technology tools that help make their day a little easier, it's money well spent. And you'll find when you have a culture of really taking care of your staff, they take care of each other more, and they will take care of their clients more. We also believe in offering a welcoming environment, because the Housing First model is about community building. It's about rebuilding our neighborhoods. It's about people, like I said earlier, being of the community and not just in the community. So we want to always be welcoming, because we want our clients to learn how to be welcoming as neighbors. And so we have designed our office to be a welcoming space. We have a calm blue on accent walls. We have overstuffed chairs and sofas, and a setup like a living room. There's coffee and tea service that's always available, and it's a help yourself. And in the summer, there's iced tea and cold water. It's available all day long. The kitchen is open and available for use. People don't have to, raise their hand or ask to use a restroom. The restrooms are available. We have showers for emergencies and washers and dryers available for emergencies. There's a library, and we have computers for people's use, and there's always someone around that can help and knows that it's part of their job to help people with the computer if that's necessary. So the space is, bright and welcoming and comfortable. So what are some of the hidden costs of housing retention? So I want to knock off the last couple slides and leave a good chunk of time for questions. So we spend a lot of money on maintenance, repairs, paint, carpeting, plumbing, lost keys, all these things that are really over and above the landlord's responsibility. People that have been on the streets for 20 years and have literally been, lying in their own poop for part of that time, they tend to be hard on apartment units for a couple of years. So nothing is bad or wrong in this. It is the cost of doing business. If you want to do this programming and you really want to reach this population, you have to be ready to eat that cost. And it means you have to be willing to do the fundraising. Like, I have to fundraise for a lot of this. A lot of the money that pays for this is private dollars. You got to know going in that you're going to have to do some of that. And you have to know that it's okay. You don't want to have your staff afraid to report needed repairs because they feel like they've done something wrong, or the agency, the administration gets upset if there are bills coming in. It all has to be looked at as, part of the business. This is part of what we do. There are costs related to utility overages, gas, electric, phone, sometimes the overuse of water. Now, water is usually the landlord's bill, but if it's, 7 times what it should be, a lot of times we will pay that because that is part of our relationship with the landlord. Replacing appliances that get sold or stolen, and which happens more than them actually breaking. Cleaning, exterminating, bed bug removal, big one. Now, bed bugs are not just a homeless problem. Bed bugs are a problem that have hit us. It's a very big problem on the urban landscape all over the city, even some of the swankiest hotels. And it's something that needs to be dealt with, and it's something that costs money. And so, again, that's something that needs to be taken care of on a regular basis, and you need to have a pot of money that is paying for that. And then, and then we have our hoarding situations, some of which are animal hoarders, and they cost money. So all of that stuff adds up. And it's hard to fit into many budget categories, but you basically have to be committed to raising it and know that it's not the end of the world and that it's not a reason to think that this person isn't going to make it. It's just part of what you have to go through in the early stages of someone being housed, sometimes. And then, there's the extras. So some of the stuff that we've built in our 7+ years of doing this work in Philadelphia, we've worked with Project Home's Federally Qualified Health Center, and we now have a fully integrated primary care clinic in our offices. And, we do house calls, and that is amazing. If you look at healthcare today, it's an amazing thing to be able to offer people. Community integrations near the top of our list. Again, we have to raise money sometimes for these positions, but it's so integral to people's wellness and to people really getting their lives back on track. We have a Columbia grant where it's a peer administered wellness program around obesity that we have a bunch of people enrolled in, and they're doing all kinds of health stuff. Benefit specialists, if you are doing case management in the state, that having as many people enrolled in Medicaid as possible will always, pay for itself. So it's important to have a benefit specialist position, especially as we start to look at Medicaid expansion. And everybody should be thinking creatively about what they want and need and what they should be asking the state to look at in terms of Medicaid expansion. Rep payee program, that 30% of people's income that they need to pay is really important. For your program to work, you need to be able to collect at least, a big portion of that. People that have been out on the streets for long periods of time are not great with their money. So for some period of time, there are going to be a lot of people that need a rep payee program. It's something to think about. And then something that we opened last year that we're really proud of is a furniture bank. So we didn't really have a furniture bank in Philadelphia that served other programs and served our community. And we decided to be that. And so we opened the Philly Furniture Bank. And last year, we served 1,080 people. We got 1,080 people up off the floor, and these were people that were moving out of homelessness. So it created flow so that our transitional housing programs in the city and our shelter programs and women against abuse and our other services like that, where we have really limited beds, we're able to move people out more quickly because they had access to furniture for their apartment units, which then created openings for people that were in bad situations that needed to come into our system. And you don't always have to have dedicated funding to start needed services. Start small with what you have. Report on successes, and then pick up pieces as you go along. And that's kind of what we did, especially around our primary care stuff. We started small, and because we were able to show some small outcomes, it helped to bring in funding. So I'm going to open this up for questions. Take a look at our website. The website's up here. If you go to the Who We Are page and the Overview page, there's a really good video that talks a lot about the how in what we do. My email address is here. I'm always happy to answer people's questions. And, we are really looking in this year
the conference has been unmuted.
A training and technical assistance institute to serve people. So if anyone is interested in training, they should get in touch with me. Thank you.
Chris, that was great. Thank you so much. We have a question from the question is, where do the monies for the psychiatrist and or nurse come from? Where are they coming from?
Great.
Yeah.
Okay. So for our teams, we actually have built the cost for the part-time psychiatrist and the full-time nurse into the rate for our case management services. So we've inflated the rate in order to cover that. Now the nurse is considered a nurse case manager. So the nurse positions are billable to Medicaid. So that position kind of pays for itself in the rate, and the psychiatrist is built in the rate. So what that means, if you're not familiar with billing Medicaid for case management services, is that you have a team, and a number of people on the team, every 15 minutes of service they provide is a unit of service, and you get paid for that. There are people on the team that don't bill. So the program assistant, who's the admin person, is not billable. The nurse is billable at 75%. 25% isn't billable. The psychiatrist we don't bill for. He's built into the rate. So the rate that the case managers are being paid for is a little higher than it would be normally to cover those additional positions on the team. Does that answer the question?
Is there a follow-up to that, or do we have other questions that people would like to pose to Chris?
Yes.
Go ahead.
Do you require that participants have medical assistance?
No, we don't. So one of the first jobs that we have when we start working with someone is to try and get them medical assistance. And, that can take 3 months, that can take 6 months. So there is a period of time that we can't bill medical assistance for that person's services. Depending on your community, you may be able to get some of that covered. So we have a contract with the Department of Behavioral Health in Philly, and the units of service that we generate that are not paid for by Medicaid, DBH pays for a portion of those to help carry the non-Medicaid billable individuals. But you have to keep an eye on that, which is why it's important, one, to have a benefit specialist, because the quicker you can flip people onto MA who are eligible, the better you're going to be. And two, if there are people that are never going to be eligible, you need to kind of keep track of that and know the whys, so that you can use that data to build a case with whoever your payer is to cover them in some other way.
Thanks, Chris. We had a question from Christina Kennedy. States we are being asked to convert a 9-family unit of transitional housing facility into Housing First. Is that feasible, especially with the team being one case manager and a supervisor and security?
Yeah, that's probably a longer conversation than for this call, but I'd be happy if Christina wants to reach out to me to talk about that. So if you're being asked to do a site-based Housing First facility, there's a lot of pieces that go into that. It's, conversion money, and can you, what's it going to look like, and do you need tax credits and stuff around the bricks and mortar. But then also, what is the level of support, and how long, if it's families that have been in transitional housing, how long do you expect the supports to last? And why would you want to do a bunch of families permanently in a building that may not need the services after a while? So there's a lot of questions there that would take longer than this to look at. Really, so my belief is, especially with Housing First, but for any population, when you talk about permanent housing, that there should be choice in the community for permanent housing, and that people should be integrated. And creating a building into a site-based Housing First program for poor families, then what do you do when the family no longer wants to live there? Do they lose their services? There's a lot of weird stuff that would have to get worked out. So, Christina, reach out to me, and I'd be happy to talk through some of what I know of other places in the country that have tried to do similar.
Chris, this is Joyce. I wanted to ask, too, it sounds like on the face of it, with limited info, that what she's describing is not necessarily what you just went through in keeping with fidelity to the model.
Right. It's not.
Okay.
It looks like they're looking to do a small S Housing First, but again, kind of what does that mean if you're doing it all in one? How do you do permanent housing all in one place and expect people not to leave is the question.
Mm-hmm. The next question from Linda is, what do you estimate is the average cost per person? I am interested in comparing the real cost of different kinds of programs.
So in Philadelphia, our cost is $28,500 per person for our program. That includes their housing subsidy, their mental health services, their drug and alcohol services. It includes emergency food and utilities. It includes it includes a lot of their primary care services, every single thing that goes into keeping this person well and housed. And if Linda wants to email me separately, I have a report that does a cost and outcomes analysis that was done by the Scattergood Foundation that can show the breakdown and the comparison to similar services in our area.
Oh, you think so?
So, thank you. Additional question for your full-time case managers, what is the billable unit requirement or goal that they need to meet per week or per month?
So we ask them to generate 420 units a month.
Do you just want to sign it?
Okay, thanks. Do folks have follow-up additional questions or follow-up?
Oh, yeah, you did. I didn't realize.
Now, That's for the full-time case managers. The team leader, the assistant team leader, and the nurses have different unit requirements, and they're a little lower. The team leader comes in at a third of that, the assistant team leader 2/3, and the nurses at about 2/3.
Have you had an opportunity to calculate roughly what a ratio would be between number of hours per unit or per
So our
patient?
clinician to client ratio is about 1-12 on our non-fidelity act teams, and it's 1-18 on our lower level of care. And again, our program is really designed to work with the sickest folks on our streets, so it's a pretty tight ratio.
Chris, can you explain what's included under the billable time?
I'm sorry, I don't understand. How do you want me to break it down?
Samantha, do you want to ask Chris? This was your follow-up question.
Oh, I'm sorry. I see it now.
That's okay.
Yes, I just wanted to know if there's any exclusions, I guess, to what could be considered billable time or any time with a client that doesn't count towards that.
So it's the basic state regs for blended enhanced case management. So, if you do your notes and you're not with the client, that note time is not billable. Collateral contacts, depending on who you're talking to, may or may not be billable. It's all the stuff that's in the state regs around case management.
Thank you.
Do we have other questions or comments? As always, Chris, you've given us a lot to think about, and thank you for the presentation, all the great work being done, everyone on the phone, and Chris, we appreciate your time today. And we will be sending out the PowerPoint presentation with all of Chris's info in it. So thanks again. Happy weekend.
You're welcome. Bye-bye, everybody.
Bye-bye.